So good afternoon. Thanks for everyone for joining today. My name is Roger Owens. I'm the Vice President of Sales, Marketing, and Operations for Haemonetics Corporation, which has recently acquired Cardiva Medical. And I'll be facilitating part of the session today. We'll be offering a QR code at the end of the session for anyone to be able to utilize your phone to ask questions for the faculty. So it's my honor to be able to introduce the faculty members here today, and I just wanted to thank each and every one of them, not only for the presentation they're giving today, but also the guidance and the development actually of the clinical data that they'll share throughout the presentation. So first we have Dr. Pat Raninsky from Texas Cardiac Associates. Dr. Raninsky is currently based in Raleigh, North Carolina, and also travels to Texas frequently, and has done his background and training at UT Southwestern as well as Duke. Dr. Raninsky has been heavily involved, along with the other Texas Cardiac Associate members, with developing a lot of the clinical data that you'll be seeing today. So thank you, Dr. Raninsky. And he'll be covering the history and fundamentals of vascular closure to give a little bit of a background on how we got to this point. We'll be handing that off to Dr. Amin Alamad. Dr. Alamad has done a lot of his training at Tufts and afterwards spent about 10 years in Stanford on the West Coast, and then has joined Texas Cardiac Associates and based out of Austin, Texas. And then he'll be covering the importance of patient satisfaction and vascular closure post-ablation, and give a little bit of feedback about where all of this originated, which was really about early ambulation, which enabled same-day discharge. And finally, Dr. Ben D'Souza. Dr. D'Souza is a true Philadelphian, trained at Villanova, and then also spent other training at Thomas Jefferson, and then did his residency and medical fellowships at Hospital University of Pennsylvania, and works currently out of Penn Presbyterian. So he'll be covering his real-world clinical and economic value using closure post-ablation, and sharing his personal experience during that. So without further ado, thank you to the faculty, and I'll pass it along to Dr. Pat Raninsky. Thank you.
Thanks, Roger. Thanks, everyone, for attending. I'm going to focus mainly on the history of vascular closure and give a little intro into VASCADE MVP. And really, for the longest time, the way we were handling our hemostasis following procedures was with manual compression, and the vast majority of people still do that, or I wouldn't say vast, but a significant number still do that. And it's been standard of care for quite some time. However, some of the drawbacks to this is the long bed rest, and particularly in the patients with AFib, the older patients, the patients with larger BMIs. This is a problem. The longer they're on bed rest, the more problems they have with pain. For men, the older men, the more problems they have with evacuating their bladder, etc. And so this also limited the ability for discharging patients as we've gotten more efficient, and the procedure has become more mainstay. Same-day discharge has become more reality, particularly in the era of COVID and trying to keep people out of the hospital. So the ability to have shorter bed rest obviously can obviate the need for these long overnight hospitalizations, the use of Foley catheters. So in moving from manual compression, we went to figure of 8 stitch, which was a good move to achieve hemostasis and avoid, manual compression and the discomfort associated with the actual compression. However, this really hasn't been evaluated for the time to ambulation in multi-center studies. There's really no data published on patient satisfaction with figure 8 stitch. And this also requires another step, which is removal of the stitch prior to discharge, or in some cases, patients being discharged and removing the stitch on their own. Then there are closure devices such as Perclose that are indicated for venous closure for certain French sizes. For sizes larger than 8 French, however, they're not labeled for single device closure. Anything greater than 8 French requires more than one device. These are non-resorbable sutures that are placed, and there is no labeling for same-day discharge or even multi-site venous closure for these devices. In addition, there are multiple steps that you must go through, particularly when you have multiple sites, which adds quite a bit of time and complexity to the procedure. So in the past, and even in the recent past, the procedural time was trivial relative to the bed rest time. And for most procedural time, particularly for AFib ablation, somewhere between 1 and 3 hours. And this doesn't just apply for AFib, this is any kind of ablation where you're getting vascular access. Procedural time anywhere from 1 to 3 hours with 6 hours of bed rest. Again, the longer the bed rest, the lower the patient satisfaction for the reasons we mentioned earlier. Older patients with back problems or with problems evacuating their bladder. It's also a less efficient hospital workflow and cost, and this was demonstrated in the Ambulate impact study. And then also, one of the bigger factors that play into this is the higher use of opioids. The longer someone's on bed rest, the more pain they have, the more back pain, the more shoulder pain, etc., the higher the use of opioids. And as I think most of us know, the FDA is really looking into this, and we're trying to limit that if we can for patients. And this could be a benefit for shorter bed rest following procedures. With the presence of vascular closure, we have moved to early ambulation and same-day discharge. So procedural times obviously aren't impacted by closure, but bed rest times are, and we've gone from 6 hours to 2 hours, shorter times to hemostasis, shorter times to ambulation, much better patient satisfaction based on the fact that bed rest times are reduced, lower use of opioids and any pain meds for that matter, and a greater potential for same-day discharge, which, as I mentioned earlier, this has been really big in the era of COVID as we have been trying to keep patients out of the hospital, and same-day discharge has been key. So this is just a quick summary of the Ambulate pivotal trial, which was a randomized clinical trial. 204 patients were enrolled. 104 into the manual compression arm, 100 into the VASCADE MVP arm. There were 13 sites and 28 physicians involved, and the randomization was 1-to-1. The primary endpoints of this trial were time to ambulation and major access site complications, with multiple secondary endpoints, including time to discharge eligibility, time to discharge, device success, minor bleeding complications, etc. But additional data was obtained on patient satisfaction and opioid use and any pain med use in this trial. And this is really a summary of the data from that trial. And as you can see, both the median time to ambulation and the median time to discharge eligibility were significantly reduced with VASCADE, from an average of around 6 hours to around 2 hours for each. And possibly even more importantly are the dramatic improvements in patient satisfaction related to the shorter bed rest time and the reduction in opioid use. A 58% reduction in opioid use in this population and 63% improvement in patient satisfaction, almost completely related to the decrease in bed rest following the procedure. Again, this is a chart summarization of that. Again, statistically significant reductions in time to ambulation and time to discharge eligibility. No significant difference in major or minor complication rates between the two. Patient satisfaction markedly improved in the VASCADE MVP arm, and a dramatic reduction in opioid use, 58% reduction in opioid use with VASCADE MVP vascular closure. VASCADE MVP is actually the first, and currently, as of March 2022, the only FDA-indicated device for multi-stick, multi-limb closure following catheter ablations, and also the first and only labeled device for same-day discharge following catheter ablations. And the beauty of VASCADE MVP relative to other closure devices is the simplicity and the ease of use. The device delivers a collagen plug, which is extravascular in the vascular tract. There's a basket that's deployed that prevents the device from expanding and moving into the vessel. It protects the baskets expand at the venotomy site. The collagen plug is released in the tract, and it expands 13-fold. Once there's bleeding into the collagen, it will expand and fill that tract. And it works by two mechanisms. First, by mechanically blocking the tract, and second, by inducing thrombogenesis in the tract and occluding it. So obviously, you wouldn't want to occlude in the vasculature, and this device does not do that. Once the collagen has expanded, the basket is brought to low profile, and the collagen slips off the catheter, and the catheter is pulled out. This whole process takes less than 3 minutes to put the device in, deploy it, downsize the basket, and pull the basket out. Again, the ease of use, the simplicity, is one of the biggest advantages of this particular device over others. And with that, I will turn it over to my colleague, Amin Al-Ahmad.
Thank you, Pat, and thank you, Roger, for the introduction and the overview. I'm going to talk a little bit about patient satisfaction, and a little bit about where the data has been and where it's going. So if you look at this slide, it's a little bit busy, but basically we asked patients when we did these studies, we asked them to rate their experience from 1 to 10. And what you see is the patients who had VASCADE all rated 7.5 or 8, fairly high rating out of 10. Now, nobody ever rates a 10 because nobody ever rates a 10. And if you have a procedure done and you have to lay flat even for a little bit, it's difficult. And actually, I would challenge anybody. I would challenge anybody in this room to sort of feel what it feels like to be a patient. So go to a hospital bed, lay flat for 15 minutes, and see how your back feels. And so I'm telling you, these patients really suffer when we do these procedures. But when we're able to ambulate them a lot sooner, they feel a lot better. And this is reflected in the very high satisfaction scores. Now, this is true whether it is a de novo ablation, they've never been ablated before, or whether it's a repeat ablation. In other words, this is their second ablation and now they're having VASCADEs. They now feel a lot better and they rate it better. Now, compare that to manual compression, where they're pretty much ranking it as a 5, which kind of means it was really horrible and they're only giving you a 5 so they don't disappoint their doctor. Because that's really not fun, having to sit there for 4 hours and not be able to use the bathroom and so forth and so on. So all this was fairly statistically significant. And again, it improves the patient in terms of pain, in terms of not needing to have a Foley catheter. So when you look at the competition or what other people are doing, there's this concept of figure of 8. Well, I'm just going to put in a figure of 8. It's cheaper. This is great. And the reality is we've had problems with it. And there's not a lot of data. All of it is sort of single center data. Some kind of retrospective analysis of things. It was one study where it looked at it versus ProGlide. But for the most part, these are very small papers, single center, and really not focused on patient satisfaction. And if you ever do this figure of 8, you'll realize that patients aren't really all that happy with it. This is why they're not happy with it. Look at the difference. And so when we did figure of 8, when we did it for a while, we did figure of 8 for a while, you'd put in an order for the nurse to clip the suture. Sometimes it didn't get clipped. Then the next day you're on rounds and the patient says, what is this? We had patients be discharged and then call up and say, oh, I've got the suture thing. I mean, this is problematic. So I'm not entirely sure how this helps anybody to put a suture in, and it certainly doesn't help our patients. And I certainly think, although you may save a few bucks, you're really not helping the patient. I don't think it's a good strategy. So a couple of words about the portfolio of studies. And I think it's really important to remember when we started this. So we started this in 2018, okay? And I just want to give kudos, first of all, to the Cardiva and now Humanetics people. How many companies do you know that can pull off real studies, 4 or 5 real studies in a matter of 4 years? I mean, it just shows you that there's a commitment to understanding the data behind it, and not just this marketing, oh, here it is, here's a device, use it. We're trying to figure it out, and that's important to me. So the Ambulate was the first study. The Ambulate Impact is an economic study that looks at what's the cost differential and are we saving money by doing this? And the answer is we think we are. And then the Ambulate Continued Access Protocol was an interesting study. That was a study I was the PI of. And it's interesting because when we finished the Ambulate study, a lot of the investigators sort of said, don't take it away from us. We want to continue. And so, when you finish a study as fast as Ambulate did, you know that the investigators liked it. And so Ambulate Continued Access Protocol was simply a continuation of that, but in particular to evaluate things like Foley catheters and to evaluate giving or not giving protamine. And then now there's a series of studies, several of which have already been completed, that are prospective studies looking at same-day discharge. Not that that's necessarily always the goal. The goal is really patient satisfaction, comfort, reduction of complications, reduction of opioid use. But again, having same-day discharge isn't a bad thing, especially in the COVID era. So Continued Access Protocol was it was a multi-center, single-arm study. We had 168 patients and 325 limbs. There were 3 sites. We were one of the sites, Valley in New Jersey and Emory in Atlanta. We did not, 98% of patients did not have a urinary catheter. It eliminated that completely. And 95% of patients did not receive protamine. We didn't give it. And they were fine. They did great. 100% of patients who were in the same-day discharge group went home. Now, this was kind of our foray into same-day discharge. We were kind of trying to see, we had a same-day discharge group, and we were trying to see, is this feasible? Is this something we should study? And it looked to us like it was potentially feasible. So when you add up what we've looked at with same-day discharge, we now have 2,143 access sites, 648 patients, 27 investigators. That's a lot of variability in sites, 8 U.S. centers, and again, 90% success, same-day discharge. Only 1 patient came back because of a little groin bleeding, 0 major complications. And so that story is good, and that's based on robust data. And again, kudos to the company for actually obtaining the data. So this is where we are now. Ambulate Continued Access Protocol is finished, and we only looked at 18 patients out of that cohort that were same-day discharge. Same-day discharge retrospective looked at 498 patients. Same-day discharge paroxysmal was finished. And actually, persistent AF same-day discharge is complete, and the manuscript is currently being written as we speak. And so the next study is same-day discharge AFib all comers. And again, it's impressive that we can do all of this in a short amount of time, but it also tells you that when investigators are willing to enroll their patients quickly, that they like the device. So I'm going to switch over. I'm going to hand it to my colleague, Dr. Ben D'Souza, to kind of tell you his experience in the real world about this.
All right, thank you, guys. So device sounds great, right? We can implant this in patients, get them up, get them out of bed. But it turns out that we have to pay for this stuff. And unfortunately for all of us who have gone through new product committee, it's probably top 2 worst things that I've had to do insurance companies, prior auth is probably, right on par with that. So in terms of the actual device and how we've utilized it at Penn and what we've been able to do with same-day discharge has changed significantly over the course of the last few years. And COVID sort of pushed us towards that, but we were already moving that direction prior. It just sort of forced us to go in the right direction. So as we've already described, we previously were doing manual compression. In fact, one of my partners still uses these giant compression tape balls on patients, and we pull off all their hair, and it's miserable. Perc close I've used in the past. Unfortunately, have had some complications related to that, related to the stitch and sometimes arterial-related issues. I saw a young girl almost lose her leg because of it. And then we did adopt figure of 8, and as we've sort of already talked about before, it's great for getting patients out of the lab, except for when you cut the stitch, and then they bleed, and then there's issues related to it. And then, our sort of adoption of VASCADE, at Penn. So, as sort of we already talked about, and I want to give a shout out to my APPs who are in the crowd. We're going to be presenting this data on Sunday for our same-day discharge information and stuff that we've done at Penn. We've had a very successful program. We were the first ones in Philadelphia to send patients home same day for an AFib ablation. Now it kind of is the norm where it's moved towards that, and I think that most programs really need to consider it if they haven't already. But listen, for all of us who dealt with the pandemic over the last few years, we were told we can do AFib ablations, but we can't keep them in the hospital. So we had anesthesia support for the most part, but we had no beds. People were filled, unfortunately, we had patients, all of us who dealt with this had patients with COVID. And so we had to get our patients home. I was already sort of moving in this direction, and then, it turns out that there's a certain time frame, and our time frame is about 6 o'clock, that our area of our outpatient area turns into a pumpkin, and you can't send patients home after 6 or 7 o'clock at Penn. Trust me, I've tried to do it later, and I got in trouble for it. So I needed to get patients up, and I needed to get them out of bed and out of the hospital and sooner. And sometimes I need to diurese them, and we talked about Foley usage or lack thereof, and a friend of mine published a paper that Foleys are clearly associated with complications. And so no Foleys, getting people up, getting them home really was the future, and we were able to do that in the setting of a pandemic. And so the initial support for this was a little bit of a struggle. And so I had to convince our administrators, well, why do you want to pay for a device when you weren't paying for something before? Well, it turns out that financially, this is very viable. And we'll talk about that part next. So throughput is important. Unfortunately, all of us have to get people in, they have to get people out. Our lab staff are wonderful. One of our now retired lab staff said, Ben, you know what EP stands for, right? It stands for elective procedures, meaning don't put that patient on the table at 5 o'clock. We're not staying late. We're going home. And listen, I love my lab staff and I love doing procedures. I also love my wife and my 2 little boys. I love going home too. And so we're kind of all on the same page. We want to go home. And if we can do that, and we can safely do that without having to add more people, unfortunately we have a shortage of people in nursing, like everything, getting people out of the hospital was very important. It's actually important to our patients too. It was actually hard to talk to a patient about doing an AFib ablation when they didn't want to come into the hospital because they thought that Philadelphia was the epicenter of COVID, like any other major city. And patients were like, wait, I can go home that day? Now, my patients say, well, I'm going home today. I'm like, well, was this an option a couple of years ago? It turns out now it's the norm, and this is what people need to strive for in terms of their program. And we've been able to do it at Penn, but vascular closure was a huge part of it. And so getting people up, getting them out of bed was vitally important. So this is just a video showing the device. So it turns out I don't actually use this device anymore because my nurses do it and my lab techs do it. I don't even actually do the procedure. I basically walk out of the room or somewhere nearby and I text the referring and I start doing my procedure note and I start working on the next things, start answering all the texts and calls that I got during my AFib ablation while our lab staff closes. So we actually have our lab staff do this. As we had mentioned earlier, it's a very simple, straightforward procedure. And so this is actually me closing a left atrial appendage closure with a Watchman. So we're able to very easily close Watchmans and pretty much most procedures. And we're not going to talk about this, but in the future, we're going to be able to close every procedure, including a micro, which is one of the few patients I have to keep overnight in terms of a procedure. But the closure is straightforward and easy. You know, in this case, we downsized the Watchman sheath to an 11 French sheath. Usually I'll give a little bit of lidocaine with epinephrine just to sort of help the vessel spasm down, and then we'll hold pressure for a little bit, and then we'll close. And honestly, we used to do figure of eights for our Watchmans and for our AFib ablations, and I can tell you that seeing my patients, when I talk to them, the very first question I ask them was like, how are your groins? How's everything where I placed it? And they're like, that wasn't even a thing. Like they can't even see the access site. And it's so incredible to me that most patients, their fear of the procedure is access. And if you talk to people who have had a cath, like no offense to my colleagues in interventional cardiology, who have had a cath like 10, 15 years ago, they're like, well, there was a clamp and sandbags and we did all this stuff. We don't do that anymore. And so when we tell people that we're actually going to deploy this device, in fact, I just did this on Monday for a patient who's a nurse anesthetist, CRNA, and she's like, wait, you have what? I can sit up in 2 hours? I thought this was going to be 6 to 8 hours. It was like her eyes just lit up. She's like, really? I can sit up in 2 hours? I can go home in 3? It really changes the game in terms of conversations about procedures. And for those of us, unfortunately, reimbursement went down for AFib ablations. We have to do more of this because, like I said, I have 2 little ones. I got to take care of both of them until they get through college. We have to continue to do procedures, and throughput is important. And this was a big part of it for our group. And so same-day discharge, again, is kind of moving towards the norm for AFib ablation. I take care of patients that are 90 to 100 miles away, and I discharge those patients. And again, we'll be talking about this on Sunday, so I'm going to give my shout-out again for our abstract that we're going to be presenting. But diuresis is not a big deal. You can sit someone up in 2 hours, give them Lasix, and still send them home. You know, there are other related issues as to why you don't send someone home. It's not groin-related issues, and it was before. Because quite frankly, if you finish a procedure at 3 and you have 6 hours bed rest, that patient isn't going home. They're going to stay. But now, 3 o'clock, 5 o'clock, home at 6. It's perfect, and everyone's happy. We have beds in the hospital, and we are able to get everybody out. So, you know, we talked about finances. So when I presented the actual use of this device to the new product committee at Penn, they're like, well, you don't use anything currently, so it's going to cost you X amount of dollars for X amount of sites. I said, but I'm going to get the patients home. And they actually fought me. I actually had to do work in terms of we looked at patients, we looked at the finances, and we looked at the savings. And so, I mean, this is one of many economic studies that have shown that it is clearly saves money. So for most of us that have to sort of pitch this to new product committee and go through the process of a device, it actually has been shown to save thousands of dollars, and so per patient. And so, to be frank, I don't care about cost savings. I care about the patient. I care about what's best for them and how they do with the procedure, how they feel. But other people, bean counters, do care about that. And so that ability to send somebody home that day changes significantly. As I had mentioned, we just don't have the ability to discharge a patient at 10 o'clock at night. And most places don't. The ability to send somebody home same day is significantly beneficial to the hospital, to administration. And this was a no-brainer when we looked at it. I mean, I've fought. I think I've sold both of my children to get new products on the shelf. I did not have to do that with VASCADE, which is good because I only have 2 kids. And so the ability to do AFib workflow and get people out of the hospital has changed us significantly. Now, I want to be clear, these cost savings don't even reflect the beds that are in the hospital. So it's really hard to actually look at that data in terms of that bed that's free, that gets taken up by a transfer in for whatever surgical procedure they're going to get. That number is astronomical. And if you actually were able to look at that data, this is a no-brainer. I mean, if you think about it, if you're doing 2 to 3 AFibs per physician per day in terms of beds every day that were not taken up, the hospital makes so much money off of this. And so it does, to me, this, again, as I had said before, I don't care about the cost. I care about the patient. But it turns out that it actually saves money, even though it's a procedure that adds incremental costs to the procedure. In the long run, it actually saves the hospital significant amounts of money. And we found this at Penn. In fact, when we looked at this data, we actually were scolded by our administrators because they realized that we were saving so much money and they didn't want us to know how much money we were saving for the hospital. So the savings are in the millions. Unfortunately, I don't get any of this reimbursement. So I get paid regardless. But again, what's best for the patient is what's best. And in fact, I close patients even if I'm not sending them home because it's the right thing to do. I can't tell you how many patients I have. Unfortunately, the obesity epidemic in Philadelphia is the same as everywhere else in the country, that we need to sit patients up. All of them have chronic back pain. All of them can't lay flat for a significant amount of time. As we had talked about earlier, if you lay flat in a hospital bed for a couple of hours, good luck to you. And so it doesn't matter. It's painful. And it's what they remember from the procedure. And it's the reason that they won't want to have something done in the future. And it really does change the whole conception when they're like, oh, 2 hours, I get to sit up, I get to go home. It's really, again, it's been game changing for us at Penn. And so yes, you can save money. Again, it's important. In terms of the adoption, so we were one of the first to adopt this in terms of same day discharge. This is a cool map. I'm going to see if it actually plays. So this is spread like wildfire. And so really the ability for us to send patients home same day, use a device that can close multiple sites. So as we had mentioned earlier, you can't close with part close if you use 2 or 3 sites, which most of us do for AFib ablations, and for bigger access sites. And the devices, as I had mentioned, I don't even use the device anymore. I just have my nurses or my techs close for me, and I sort of move on with the rest of my day. And I'll leave it there for any questions.
D'Souza. Thank you, Dr. Alamad, and then Dr. Raninsky. For those in the audience, I think we're going to pull up a QR code as soon as we get the sound adjusted a little bit on that one. But if there's any questions that you'd like to ask, if we could bring up the QR code, that's great. And I'm not sure if my mic's on or not. Okay, thank you. So if you'd like to ask a question, if you can direct your phone to the QR code and then submit your question, I'll gather these as we move forward. Just a couple follow-up questions that we've received. Dr. D'Souza, you shared a little bit about the ease and simplicity of being able to see the added cost during the procedure. That's just supply cost. Can you offer any advice for anyone who's trying to go through the process with their administration on how to kind of capture the value or cost savings as they may try to put that into their calculator?
Yeah, it's a good question. Unfortunately, when you present this stuff to new product committee and say, well, the patients are going to feel better, unfortunately, they don't care. And so it really comes down to cost per case, and they look at the revenue of what that is. So when we started this, it was based on same-day discharge. So I recommend to people that say, who specifically are not sending their patients home, or who are, but are going back to a room or a bed that takes up space for 4 to 6 to 8 hours, that time is where the money is. And that ability to do an additional procedure is where administrators say, okay, I'll listen to this. In fact, we were instructed when I first started this, only use this for patients who are going to go home same day. Do I do that now? No, I do. For any of us who have done this before, when you get a product through new product committee, they stop looking. They're like, They hear another fire engine and they move on to the next one, like a puppy. And so it really is not, I do what's best for the patient. And I think that if it were me, and I shared this story earlier, the person who runs new product committee, I take care of his brother. And when he has an AFib ablation, I asked him, I said, well, what do you want me to do? Do you want me to use this device and send you home or not? And it was a no-brainer. So if I'm going to do that for the person who runs the new product committee's brother, why can't I do it for all my patients? And I think it's the right thing to do. Quite frankly, if it were me, obviously this is, easy. I want to sit up in 2 hours. I don't want to sit up in 4 to 6. But you have to go through the financial gain. And when you look at cost per case, they're going to say it costs more, but it really doesn't. It actually benefits the hospital significantly. And so that's the argument that I would make to people who say, well, why am I going to add costs? And I've talked to many people like groin issues are not an issue. They are. If you talk to patients, the very first visit, the first thing that you need to ask them is about groin-related issues, and that's the major reason that they complain about the procedure. And all of us have Press-Ganey scores or whatever they're going to be. Unfortunately, we are judged on our outcomes, and not even the outcome of the AFib ablation, how the patients feel, and it's significantly improved if you can set them up.
Okay, thank you.
Roger, when we were getting together early on to discuss the study, we realized a couple things. We realized that there were investigators where the procedure ended and they would wait until the ACT came down and somebody would pull, and that patient would stay in the lab until that happened.
Yeah.
So that patient's now occupying the lab for 10, 15 extra minutes until the ACT comes down and some person is pulling. And that's not how we do it. What we do is we used to send the patient to recovery with the sheath in, and then we would send somebody down to recovery and they would pull in recovery. But now that's a person that we're sending down. So in both case scenarios, you eliminate that issue. You eliminate the amount of time they're waiting on the table, reducing, which affects your turnaround time, makes it slower. And you're also reducing the idea that you have to send somebody downstairs to recovery to pull a sheath 20 minutes later and take that person out of circulation from doing other things that are necessary to keep the lab moving. And so you do save money from that perspective as well.
Okay. Dr. Raninsky, any?
The other thing about this is Ben touched on the cost of disposables, and sometimes this is a hard argument to make because you have a different group of people that are counting the beans related to the disposables for the procedure than you have that are looking at the cost savings about same-day discharge and reduction in staffing to take care of a patient, et cetera. But in addition to saving in the global aspect of things, other important issues when taking this to the committees particularly has to do with quality, because every hospital wants to improve quality, and the quality assurance committees, when they see that you're using, particularly when you're using less opioids for these procedures and the pain scales that are related to these procedures are improved, these patients, they have to fill these out, or the nurses have to fill these scales out on behalf of patients for every single procedure. I mean, the nurses know you're doing this constantly. What's your pain? What is it on a scale of 1 to 10? You're constantly asking. They're using this data, right? And they're using and the FDA is also looking at this, and trying to reduce the use of opioids, both in and out of the hospital. This is another angle where the hospital, when the hospital looks at it, it's like, oh, okay, in addition to better patient satisfaction scores, in addition to global cost savings, I'm also, I can check this box that our pain scores are better and our use of opiates is better as well.
Thank you. And Dr. Raninsky and Dr. Alamada, I know that you guys do procedures at a number of different hospitals. This is related a little bit to Dr. D'Souza's comments about the techs closing. Any commentary around when you go to a different facility, are the techs typically closing, fellows, or do you typically close? And is there any commentary about the learning curve of teaching those people?
I can start with that one. We do a fair amount of outreach in our group, so we'll go to different hospitals. At our main center in Austin, we've trained our techs to do it, and we've trained them to use ultrasound and close, and it's very simple and pretty much bulletproof. When I do go to outreach centers, it depends a lot on which center and who the techs are, and are they trained on this or not. And if I'm not sure, I'll just close. But again, it's literally, I don't know, Pat, you said it was like 3 minutes. It's very fast. It's trivial. So I don't mind doing it. But yeah, it's easy to train techs to do this, or nurses. Yeah.
I'll echo what Amin said. I mean, like Amin, depending on what hospital I'm in, there may be techs closing, there may be a fellow closing. I may do it myself. The one thing that is important to remember about VASCADE, despite the simplicity, is there is a learning curve, as there is with any new product, right? So when bringing it to your lab, you want to make sure that before you hand it off to the techs, that the techs, as Amin said, are trained to do it, right? There's a little bit of a feel to it that doesn't take very many cases to understand, but yeah, I mean, it really just depends on where I am, whether I do the closure, whether the tech does the closure, or whether if there's a fellow there, the fellow's doing the closure. But
Dr. Rudninsky, I'll direct this to you to start. But any concerns with reaccess of the vein after a short term or long term? Because obviously a lot of redo patients, you see a lot of this.
If you need to go reaccess, there's no danger in doing so, right? You're not going to have a non-absorbable suture in there and have to be wary of where you get access. I mean, despite the fact that all of us like to think that we never have to do redos, we all have to do redos, and going back in is not an issue in patients that have VASCADEs in, because again, this is a bioabsorbable collagen.
And Dr. Al-Ahmad, I'll send this to you, and I'm paraphrasing it a little bit here, but are there any considerations, special considerations or changes for patients who have a really high BMI or a very low BMI with the procedure as well as the ambulation times?
Yeah, I think those can be challenging patients. What we typically will do is we'll get groin access with ultrasound, and whether it's high BMI or low BMI, really haven't had too many problems with it. Initially, what we were worried about with low BMI patients was that if you deploy it, would some of it stick out of the body? If you make your needle tract in such a way, there's a way to do it where it doesn't. And I've been using it with low BMI patients without a problem. High BMI patients, we do go back and do another groin check on them, okay, just to make sure, because there's a little bit more pressure down there that can affect this. As they come out of anesthesia, sometimes their venous pressure goes up dramatically. So we do a groin check on them, but that takes very little time.
Okay. And you shared with me previously, and again, the 2-hour ambulation time, we were kind of using that for an arterial guidance because that was on the arterial side, and that's why we use that as part of the protocol for the Ambulate trial. You have shared with me in the past that you, and I don't want to paraphrase this, but you take a look at ambulation times for normal BMI patients, obviously general anesthesia being the rate limiting factor, but for normal BMI patients, do you find that you're allowing them to sit up a little bit earlier than 2 hours, or?
Yeah, that's exactly right. I think within an hour they can be up and around. I think the biggest issue we have, honestly, is anesthesia and making sure that they're awake enough to come out. They spend about an hour in the PACU, maybe sometimes a little longer. By the time they get to the room and they're literally they're ready to get up right after they get to the room. So they're awake enough. Yeah.
And Dr. D'Souza, I'll send this to you. We've talked a little bit about this, and I think any commentary from any of the other faculty members would be appreciated. But when you're typically getting calls from other colleagues, and if you were the first to implement same-day discharge in Philadelphia, what are typically the questions or concerns and advice that you have for those incoming calls? I don't know what those are.
It's a good question. In terms of, so we're talking about BMI, just to answer that too. It's not so much the BMI, it's so much the distance that is when you get access, right? So when we're doing vascular access, normally this sort of, for me, if I'm using a 5 centimeter cook instead of a 7 centimeter cook, if I have to use a 7, probably not ideal in terms of closure. Just the distance, more so than the actual weight. But I agree, following up on those patients regardless. In terms of same-day discharge, for me, and again, we're going to talk about this on Sunday too, is kind of cherry picking the best patients, right? So it turns out that vascular issues are the least of the issues regarding sending patients home. It's generally anesthesia or respiratory related issues and heart failure. And so patients come in and their LA pressure is 25. I'm like, I'm not sure this is the best person to send home because they're floridly in heart failure doing their procedure. But what we've done more recently is sit them up in 2 hours, give them a dose of diuretics, IV, send them home with 5 days of diuretics, and they do fine. And they don't bounce back to the hospital, which is what we're all looking at in terms of, unfortunately, visits to the hospital within the 30 days or just in general, readmissions or heart failure related issues are an issue in terms of patients who have fib ablations. And so I think that for me, it's not, the groin stuff is no longer the rate limiting step. It's the other things, social support at home and, sort of management of pain or related issues, but largely heart failure. And I think that's kind of the main issue that we've had in terms of bounce backs. I mean, quite frankly, if you're looking carefully, you're not going to miss an effusion. You're not going to send a patient home who's going to have tamponade. Knock on wood, I've never had a single patient that I didn't know already that I needed to admit them. But groin stuff is, that's no longer the rate limiting step in a procedure, which is great because it was before. I mean, prior to this, we were not sending patients home because they had issues. I mean, they either had bleeding or pain, or they had to lay flat and felt uncomfortable, as we had talked about narcotic usage, and not feeling well enough and wake enough to be able to go home. Now that we wake them up, sit them up, home. It works perfectly.
Okay, thank you.
Yeah, what I typically tell people that want to start a program where they want to start doing same-day discharge is use the CHADS VASC score. So if the CHADS VASC score is a 0 or a 1, those are generally healthier, younger people, and I say those are people who you would start with. Get those patients out. And once you get comfortable with the idea and you have a process, because one of the things we do is we have a nurse educator talk to the patients before they're discharged. So it takes a little bit of logistics to coordinate when are they going to come and talk to the patient, things like that. So once you have that process going with those easy patients, then you can kind of expand it as needed.
And I think the last question, and this was, again, paraphrasing, talking about figure of 8 and patient complaints, but can any of you share any direct feedback that your patients may have had who have had a procedure using figure of 8, because all of you have used figure of 8 at one time, and then had a redo procedure under the new workflow and new closing process? Any feedback on that?
Well, there's no doubt, and I think Ben and Amin will agree, there's no doubt that the best advocates from the patient standpoint for this are patients who have had it done both ways. Patients that have had either manual compression or figure 8 and have had MVP closure. And those are the people that are the most outspoken about how much better it is. And again, mainly not just related to pain, but the biggest factor is just the time for bed rest. But absolutely, those are the best advocates for the closure.
Yeah, so one of my favorite things by accident that happens is, we use templates for our notes, and I'll do a Watchman, and I'll have a template in that I put a stitch in, and then my wonderful APPs who are in the audience will go in the next day, because I actually closed with VASCADE instead of putting a stitch in, and they walk over and they're like, oh, thank God, I don't have to take this stitch out. Because honestly, for us during the procedure, the stitch is fine. It gets them off the table, but we don't have to do the follow-up. Right, so for those of us who actually have to pull the dressings off who actually have to do the compression. When I was a fellow, I had to do that. I don't have to do that anymore. So for docs who are like, it's not an issue, it's because you're not actually talking to your APPs, your fellows, or your patients in terms of what the follow-up actually is. And it's quite frankly what they remember the most. And so I always think it's funny because I'll get the call like, Ben, was there a stitch in here? I'm like, oh, sorry, that was the wrong note. No, there's no stitch. Like, they're good. Get them home. And so it really is a benefit to not just me and not just to my patients, but also to the other people that I work with.
Great. Dr. Mean. So thank you all to the faculty. I think that's all the questions that we had, unless anyone has any additional questions. But Dr. Reninsky, Dr. Alamad, Dr. D'Souza, thank you for your time and sharing with the group today.
Thank you, guys. Good to see everybody.
Thanks for coming.